let's go to clinical applications very quickly. Differential diagnosis is a area of clinical application of perfusion. It means let's try to understand if a certain brain lesion is a tumor and what type of tumor. Is it a glioma, is it a lymphoma, or meningioma, or something else? Molecular profiling of gliomas is another area of application. It means that once I think that one tumor is a glioma, I may be interested in whether has IDH mutation, it has one P19Q codeletion, or other molecular signatures that are important for a correct diagnosis. And then the holy grail of neuroradiology, of at least brain tumor neuroimaging, distinguishing true progression for false progression or pseudo progression or treatment effects. We'll talk about that in a little bit. So these are three big areas of applications of perfusion. I'm just gonna show a couple of articles just to give an idea. This is a study where they show that lymphomas have higher K-trans than glioblastoma, and they also, like, when considering all the groups, and they show how the reason may be that in lymphomas, lymphoma cells infiltrate between the basal membrane and the endothelium, so they disrupt the blood-brain barrier more than glioblastomas. So the extravasation rate is faster in lymphomas, essentially. Similarly, they also showed that since glioblastoma has more neuroangiogenesis in terms of biological behavior than lymphomas, CBV is higher in glioblastomas than lymphomas. And so not only K-trans, but also CBV can help us differentiate. An important aspect of this article is that they selectively chose atypical glioblastoma, which is the glioblastoma lesions that do not have necrosis in the middle, because if you have necrosis in the middle, you don't really think that that could be a lymphoma, at least of a immunocompetent patient. So they specifically enrolled patients whose glioblastomas could look like lymphomas and mimic lymphomas, essentially. Other application for the same, of course, I'm talking a lot about this differentiation, lymphoma versus glioblastoma. The reason is that it's a good paradigm to show how all of these different techniques that we talked about can help differentiate. So this is why I'm talking over and over again about the same topic. PSR, as we said, is different between lymphomas and glioblastomas. And this is a historical article where they're using a very T1 sensitive sequence with flip angle 90 and non-preload. There's an article showing that with 60 degrees and 1/4 preload, so not really a full preload, but just 1/4 of preload, you still see some differences between lymphomas and glioblastomas. However, probably the accuracy of differentiation is already softer than in PSR, fully PSR optimized protocols. Finally, this other article that I mentioned before, where a full preload means that the PSR is not going to differentiate glioblastomas from lymphomas anymore. So this is to say that if you are interested in PSR, you should actually acquire PSR optimized sequences. In terms of molecular profiling, very fast, I want to mention how CBV and also PSR have been extensively used to try to differentiate IDH status, 1p19q codeletion, even CDKNA2 status and whatnot. There's also meta-analysis on this topic showing how you can use CBV for IDH status prediction. Finally, what's most interesting and most complicated, in my opinion, is the concept of pseudoprogression. So first of all, a nomenclature note, because what we're talking about is that glioblastomas after treatment, and specifically after radiation, can show some areas of contrast enhancement that are not necessary. They look like progression of disease, like the tumor is growing back, but it's not always like that. Sometimes this area of contrast enhancement can revert back and disappear, essentially. So from a radiographic standpoint, a radiology standpoint, we call this pseudoprogression. It's also a Rano nomenclature where we see something like a new progression-looking lesion, but then it goes away or it stabilizes. It's called a pseudoprogression. And this is tightly linked to the concept of radiation necrosis. It's been seen that radiation therapy can cause necrosis in the brain and or within the tumor tissue. So some of these alterations can be referred to necrosis. Some other times it's more like radiation-induced or treatment-induced changes in the lesion or in the brain, uh, such as, and we call them treatment effects. So, for instance, hyalinizing vasculopathy, reactive gliosis, inflammatory changes, and whatnot. So there are a lot of different things that are happening. Some of these definitions are radiologic definitions. Some of these definitions are pathology definitions. So there are some overlaps. So PSP, pseudoprogression, and radiation necrosis sometimes are the same thing, sometimes are not. Sometimes we talk about treatment effects. So the nomenclature is very sparse, and there's a lot of overlap, incomplete overlap between these terms. Very complicated topic, and some, unfortunately, quite often it can happen that more than one scenario coexist. So you can have residual recurrent disease, so a progressive disease, pretty much, that coexists next to radiation necrosis and treatment effects. So some cases that appear like this could also be mixed cases that have both features. So it's sensible to say, well, if it's real progression, it should be glioblastoma growing back and expanding its vasculature. So it should show higher perfusion. So high perfusion, true progression; low perfusion, false progression, pseudoprogression, or radiation necrosis or treatment effects. This could be true, and we use this notion in the clinical practice already. However, it's not that easy. If you see in the literature, there are meta-analyses showing this, and pretty much almost like the majority of the studies show that CBV, so perfusion-derived CBV, can differentiate true progression from pseudoprogression. However, if you look at the cutoffs, they're all over the place. Cutoff means, for instance, here 175 means that in this study they found that above 1.75 it's real progression, and below 175 it's false progression or radiation necrosis, whatever you want to call it. So the cutoffs are completely different across studies. 1.75 here, but 7.07 here, or 3.25. Like they're very different across studies. And there are negative studies that exist where they found no benefit of CBV, ADC, and even radiomics in this specific study to differentiate true progression from false progression. But why do we have this issue? Why is it so hard and so inconsistent to come up with a clear cutoff and a distinction between these two um, entities? So first of all, there are mixed cases, as we said. So maybe we have radiologic features of prevalently radiation necrosis, but then the tissue is both radiation necrosis, but also pockets of recurrent disease. So mixed cases are very difficult to handle and to diagnose. Um, the other aspect that we already mentioned is that PSP is a category that has different biologies inside. So it can be radiation necrosis, it can be no necrosis but treatment effects, it can be inflammatory changes. So sometimes different studies are looking at different things, or even within the same study, you have some cases of radiation necrosis and other cases that are not really necrosis. So it's very hard to differentiate clearly. The other aspect which is linked to this is heterogeneity in ground truth. So some studies have histological samples to say these cases were necrosis, radiation necrosis. These cases had uh, recurrent disease, but other studies don't have histology. They only have follow-up imaging. So they say this case didn't evolve over time, so it was a false progression. Um, so we're comparing studies that have different ground truths. And on top of that, even studies that have histology that sounds like it's the best possible situation where you have histology, but first of all, you still have mixed cases. So you can have radiologic features of radiation necrosis, but then 10% of the tissue had actual progressive disease. Well, that should be categorized as progressive disease because you have to treat the patient now, but the radiologic features were more radiation necrosis because the majority of the tissue was radiation necrosis. And histology can have sampling artifacts. You can get one certain area of the brain lesion that has features that doesn't have progression features, but another area does have progression features, and you did not sample it with a biopsy. And on top of this, there is no real consensus of what progressive disease is in histology because there are dormant glioblastoma cells, but it's hard to say when it's actual recurrent disease or not. You can see mitosis and Ki67, but that's the best you can do. And then there are technical heterogeneity factors in perfusion. So as we said, there are different degrees of T1 sensitivity. So some studies used MRI protocols with more T1 sensitivity that underestimates CBV. And some studies used more modern, let's call them, protocols that have less T1 sensitivity. So they estimate CBV more accurately and it's going to have higher values than the other protocols. What are factors that lower the sensitivity of T1? Lower flip angle, lower echo time, lower lower repetition time, and the use of preload. If we plot the cut-offs of those studies over the year of publication, we see a trend of going up. And this maybe suggests, in my opinion, that older studies that used more T1 heavy protocols were underestimating CBV, and this is why the cut-offs are lower. But of course, there are a lot of confounding aspects that that explain why the cut-offs are inconsistent. So in the real world, you cannot, we talked about DCE, DSC for CBV, and DSC for PSR. In the real world, you cannot have all of three. You can either do option A, you just want CBV, you do a non-preloaded flip angle 30 or 35 DSC, and you get accurate CBV compliant with the guidelines that we saw before. Option B, you care about PSR, you can use PSR as a preload. So PSR without preload, PSR optimized DSC without preload flip angle 90. And now that you injected a preload, you get a DSC preloaded flip angle 60 for CBV. So now you get PSR and CBV. Or if you want DCE, you can do DCE and use that as a preload for DSC and then use a CBV optimized DSC. So there are no strategies to do all three of these. And still, you have to choose maximum 2 out of 3. But if you do choose 2, you still have to repeat the sequence 2 times, which is a lot of time, and inject the contrast agent 2 times. One for the either PSR or DC that you do as a preload, and the second one would be the preloaded CBV. And the other problems and open issues are across institution heterogeneity that limits universalizability. So now I want to speak about some studies that we performed. I want to speak about some studies that we performed